Okay, so we're going to begin with we're going to be talking about the neurological system. And as I was preparing this lecture and got to thinking, this will not be on your exam because you don't have the opportunity to ask me questions, to clarify anything. I didn't think it was fair, even though you'll hear the lecture, to have any kind of interaction or practice, and then it be on the test. So, collective sigh of relief. All right, here we go. So as always, we always start with the structure and the function. So our nervous system is broken into two parts. We have our central nervous system, which includes our brain and spinal cord. And then we have our peripheral nervous system, which is all the nerve fibers outside the brain and spinal cord, which includes 12 pairs of cranial nerves, 31 pairs of spinal nerves, and all their branches, which carry these sensory messages to the central nervous system by afferent fibers from sensory receptors, and then the efferent fibers, which send motor messages from the central nervous system to muscles and glands, as well as autonomic messages that help to govern our internal organs and blood vessels. So here are the structures of our central nervous system, which is our brain. And you can see how it's everything is kind of broken down and where things are. And just to remember that our brain is two hemispheres. We're going to talk more about that. Okay, so let's talk about the components of our central nervous system, our brain. We have a basal ganglia, which are large bands of gray matter, which, like I said, two cerebral hemispheres that form this subcortical associated motor system, which initiate and coordinate movement and control automatic movements of our bodies. The thalamus is our main relay station where sensory pathways of the spinal cord, the cerebellum, and the brainstem form synapses. And then our hypothalamus is where our respiratory center is, along with some other basic functions such as appetite, sex drive, temperature, heart rate, blood pressure, sleep, anterior and posterior, pituitary regulation, and the coordination of our autonomic nervous system. Just to name a few. Okay, and then our cerebellum is this coiled structure located under the occipital lobe, which is concerned with coordination of voluntary movements, equilibrium, and muscle tone. Our cerebellum doesn't initiate movement, but it coordinates it so that our movement is smooth. So we need our cerebellum in order to do things that are coordinated, such as playing the piano, swimming, juggling, and this is all handled, even though it adjusts and corrects voluntary movement, but it does it below conscious level. Okay? And then our brainstem is the central core of the brain. And it consists of nerve fibers, cranial nerves 3 through 12. And our brainstem is broken into three parts. Our midbrain, which is the most anterior part, with a tubular structure of the spinal cord that merges into the thalamus and hypothalamus, that contains many motor neurons and tracts. Then our pons, which is an enlarged area containing ascending sensory and descending motor tracts. And then our medulla, which is a continuation of our spinal cord into the brain. And it contains all the fiber tracts connecting the brain and the spinal cord. And if we go back just for a second, so then you can see where, I don't know if you'll be able to, let's see. I always have issues with this laser printer. Let's try it. Okay, so we talked about our hypothalamus, which is right here, and then and our thalamus. Pituitary gland is kind of hanging off the edge right here. You see our brain stem, and then we talked about how we had the midbrain, the pons, and the medulla, and then here's where our spinal cord starts. And you can see this is like a slice in, lateral view. This is more of a vertical view. We have our corpus callosum right there. So those are all and then our basal ganglia right here. So important to know what each system or component, I should say, does inside our brains. Okay. So when we talk about our spinal cord, this is a long, cylindrical structure of nervous tissue that occupies the upper 2/3 of the vertebral canal from the medulla, remember where the medulla was, to about L1 to L2. It's main highway for ascending and descending fiber tracts that connect the brain to spinal nerves and mediates reflexes. We have these nerve cell bodies or gray matter that are arranged in a butterfly shape with anterior and posterior horns. So the pathways. So we have, we'll talk about sensory and motor pathways. So, but the important part of all this is to realize that, which those of you who have taken care of patients who have, say, had a stroke, know that the way our brains are wired, the left side of our brain handles the right side of our body, okay, and vice versa. So it's helpful to know that information and where the fibers cross so that you can understand the clinical presentation of a patient. Okay? So let's begin with the sensory pathways. So it's twofold. There's a spinal thalamic tract, which allows us to sense excuse me, pain, temperature, crude and light touch. Okay? So these sensory receptors are embroidered into our skin, mucous membranes, muscles, tendons, and viscera. So they're fibers that enter the dorsal root of the spinal cord and synapse with a second sensory neuron. And then at the thalamus, kind of remember where that was located, fibers synapse with a third sensory neuron, which carry the message to the sensory cortex, so we're able to interpret what we are feeling or what we're sensing. This monitors conscious sensation, and along with internal organ functions, body position, and of course reflexes. So, and then in the posterior columns, we're able to sense our body position, vibrations, and finally localize touch. Okay, and then this is the pathways. And you can see how it crosses through the thalamus and through our brainstem. Pons, medulla. So it's actually starting down here. So this patient is, touching, it's a finger and they're touching something, and then that is being, that impulse is being sent this way. So up that sensory pathway. So the green is the spinal, I can't even say it, where it's the lateral tract of the spinal thalamic tract. The red is the anterior, and then the blue is the posterior columns, or fine touch. So depending on what is going on, so if we don't have pain but we're feeling like a fine touch, then it's going based on our posterior column and going up through our brainstem, through our thalamus to the cortex, so that we can interpret what we're doing. And what I find fascinating, and I never really, thought about it a lot, is that this all happens like almost instantaneous, like the speed of sound or light or whatever is fastest. And I also want you to be aware that the sensory cortex is arranged in a map. So again, if this was your right hand or the patient's right hand, it is going to, as you can see, it's going to the left side of the brain. So we're going to assume this is the right hand. It doesn't say it, but it's going to the left side. So if it was the left hand, it would be going to the right side. So just good point to remember. But some organs are absent from the map, such as our heart, our liver, our spleen, and so you don't feel that pain there, but you do get referred pain. So, for instance, if we were talking about somebody who's having, like, their heart is in pain because of an occlusion or whatever, so they're feeling chest pain, so I know it gets a little tricky. Like, do they really feel it in their heart, or it's because it's referred? So they're feeling like that crushing pain on their chest, which men typically feel, or the pain radiating down their left arm. Women may feel it, because we feel it differently, going up their jaw, their upper back. I knew a woman say her mother, the way she felt it was like she said somebody was pinching her chest all over. So you have to remember it could be referred pain. Okay, so the cerebral cortex is the cerebellum's outer layer of nerve cells, and it is the center which functions thought, memory, reasoning and sensation, and voluntary movement. And it's, again, 2 hemispheres, and it's divided into 4 lobes. This is, some of this is a refresher. So this is what our cerebral cortex looks like. And I want you to, so we have, just to make note, I think it's important to know which each lobe is responsible for. Okay, so our frontal lobe, which is here, is responsible for our personality, behavior, emotion, intellectual functions, and within that lobe we have a Broca area, which does motor speech. Okay, and then here we have the parietal lobe, which does sensation. Our temporal lobe is responsible for hearing, taste, and smell, and within that we have this Wernicke's area, which does speech comprehension. And then our occipital lobe is our visual reception. Okay, so excuse me. So, and then our cerebellum, which isn't truly a lobe, but I think it's still important to know, does motor coordination, equilibrium, and balance. All right. So because when we just talk about damage on, somebody has damage in their brain, and then, excuse me. it's important to know what produces that corresponding loss. So like muscle weakness or paralysis or loss of sensation, or language issues, like I mentioned. So if the BRCA in the frontal lobe gets damaged, so the frontal lobe is damaged, which could change a patient's personality or their behavior, and it could also affect their language. And if that were to be damaged, they would have expressive aphasia, meaning sometimes they can't talk, but in my experience, I've had patients who could, but everything comes out gibberish. So I don't understand them. They understand what I'm saying, but because that the motor speech is coming out different. And then not reverse, but on the other side, when Wernicke's area is damaged, now we have receptive. So that's the comprehension part of the speech. So we have that comprehension is lost. So now they have receptive aphasia. So they can talk and they sound normal, but they have no idea what you're talking about because you sound like you're speaking gibberish. So it's important to kind of know what areas do what, so that if patients have issues, we kind of know which lobe is affected. And as you know, damage occurs when highly specialized neurologic cells are deprived of blood supply. So such as the cerebral artery is occluded, and then the patient may have a stroke. So when we talk about motor pathways, we're talking about either the corticospinal or this paramental tract, which permits very skilled and purposeful movements. And if they're arranged in a pattern, they're called a somatomotic organization. Or they could have, we also have extrapyramidal tracts, which are where our motor nerve fibers are. So, and which encompasses that is our motor cortex, our basal ganglia, brainstem, spinal cord, okay? They maintain muscle tone and control body movements. And remember our cerebellum, we talked about it, maintains equilibrium and our movement, posture. It's receiving information on position of muscles and joints. So this is all working in concert so that we'll be able to move in a controlled and smooth way throughout our day. So, and then this is where these, again, motor pathways are. So we're looking at that patient's right finger, we're going to say right finger. So now it's going to be this lower motor neuron that's going to go up the spinal cord and into different areas of the brain. So, okay. So we have neurons. We have upper and lower neurons. So the upper neurons are a complex of descending motor fibers which influence or modify the lower motor neurons. And they're located completely in the central nervous system. They convey impulses from motor areas of the cerebral cortex to lower motor neurons. And if there is a problem with the upper neurons, like if there's some kind of disease, typically what we see is a patient who's had a stroke, a CVA, cerebral palsy, or muscular sclerosis, MS. Now, our lower neurons are the final pathway into the muscle. They're located in the anterior gray column of the spinal cord. But the nerve fibers will extend into the muscle. They help translate into action, movement by the lower motor neuron fibers. So like cranial nerves, sensory nerves of the peripheral nervous system. And diseases of the lower neurons are spinal cord lesions, poliomyelitis, or ALS, Lou Gehrig's disease. So reflexes, okay. So they're a basic defense mechanism of the nervous system. They're involuntary. They're, they're below the level, so that we do it unconsciously. They permit quick reaction to something that could be painful or damaging. We have 4 types of reflexes. Deep tendon, which is the ones that we check typically with a patient. We can have superficial ones, you see examples of that, or visceral ones, and then, so those are all normal, and then we can have pathologic ones, which are not normal, which you could see if somebody has damage to their brain, like a Babinski reflex. And then this is the arch that we see. So it starts in the dorsal root ganglia, and then we have, like I mentioned, sensory nerve, and then motor nerves that are innervating the muscle. And so when we hit the tendon, here in this case the patellar tendon, we get a reflex. Okay. So cranial nerves. So they enter and exit the brain rather than the spinal cord, and they cranial nerves 1 and 2 extend from the cerebellum, or the cerebrum, and then cranial nerves 3 through 12 extend from the lower part of our brain into the brain stem. We have 12 cranial nerves that supply primarily the head, neck, except for the vagus nerve, which travels to the heart, respiratory muscles, stomach, and gallbladder. Okay, spinal nerves. We have 31 pairs of spinal nerves that arise from the length of the spinal cord and supply the rest of the body. And they're named for the region of which they arise. So we have 8 cranial, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal, 1 in our coccyx. They're mixed nerves, so they contain both sensory and motor fibers. They innervate particular segments of our bodies, which leads us now to talk about dermatomes. So dermatomes are circumscribed skin areas supplied mainly from one spinal cord segment through a particular nerve. They can overlap, and the nice thing is if a dermatome is severed, you don't typically lose sensation because it can be transmitted to either the dermatome above or below. But I think it's important that you know the landmark dermatomes, such as the thumb, middle finger, and fifth, or little finger on each hand, which is the landmark for C6, C7, C8. Annexal is at T1, nipple is at T4, umbilicus T10. The groin is L1 and the knee is L4. I think those are important to know but I don't expect you to know every dermatome. That's a lot of dermatomes because you see them, they're mapped out. So, and they're all coming from our spinal cord. So yeah, so I don't expect that. Okay. But I do expect you just to know about dermatomes and stuff. You'll learn more about this in pathophysiology, but there are certain things that patients will get, like disorders, diseases, and it affects their dermatomes. So let's talk about the autonomic nervous system. It's part of the peripheral nervous system, which has cranial nerves and spinal nerves. They're divided into 2 parts, their functionality, and the somatic, fibers, which innervate our skeletal muscles, which are voluntary, and then our autonomic fibers innervate our smooth or involuntary muscles, cardiac muscle and glands. So our autonomic system is on the unconscious level. So we don't, if we had to tell our heart to beat every minute, or every second, we'd never get anything done. So that's the nice thing, we have an autonomic nervous system. Okay, so let's talk about some developmental differences. So in infants, their neurologic system is not completely developed at birth. Okay, so it continues to develop over time as they go through infancy. So when you see a newborn, you will see primitive reflexes, but these will disappear as the infant gets older. So, but if they tend to persist after the age they should be gone, then that is an indication of their central nervous system having some type of dysfunction. So, and their sensory and motor development will proceed gradually when they acquire myelin, and so that they can, which is needed to conduct most impulses. So as this myelin, I'm sorry, I said melon, didn't I? Okay, myelin. So as they acquire myelin, so as myelinization develops, the infant will be able to localize stimulus more precisely and make more accurate motor responses, instead of just kind of arbitrarily finding out they have two hands because they happen to just grab them both. As they get older in infancy, they realize, oh, I can actually, and that's when we ask parents, do they have a pincher grasp, so they know that they can actually pick things up. So now things are working. And think about it, what, so now we think about, okay, what controls fine movement? It's part of that function of our brain, right? Okay, so now when we talk about aging, this is normal aging kind of process for our geriatric population. They will have atrophy, so they get a steady loss of neuron structure. The velocity of nerve conduction will decrease, making their reaction time slower in some of our older patients. And they will, get this diminished sensation of touch, pain, taste, and smell because of this increased delay at the synapses, and then their muscle strength and agility will also decrease, along with their cerebral blood flow and oxygen consumption, which could show a general slowing down of movement, which could cause dizziness and a loss of balance. So when we are doing our HPI on somebody who has a neurologic issue, you're still going to use your mnemonics that you've been doing, and which I can say very well. But in the neural exam, or the neural complaint, to be more precise, you want to ask a little more kind of specific questions. So like with headache, if a patient comes in and they're complaining of headaches, then I will ask about, do they have an aura? Like this, do they see something that can kind of tell them that the headache is coming on? Does light or sound make the headache worse, or is there no difference? Along with nausea and vomiting. Also about head injury, some patients who have a head injury, such as like a concussion or something like that, it's really significant, will have chronic headaches afterwards. So I also want to know about loss of consciousness. When it comes to dizziness versus lightheadedness, a lot of patients will just say, I'm dizzy. They don't quantify or distinguish between the two, so I usually will have to ask, is it that the room is spinning or that you feel like you're going to pass out? So if it's the room spinning, then it's dizziness. If it's I feel like I'm going to pass out, it's more lightheadedness, and I may go down a different path when questioning them. But if it is, yeah. So, and then with seizures, I want to know, did they get was it witnessed or not? Did they have a warning sign? Most of my patients who typically get seizures or think they had a seizure will go to the ER. They don't always show up at my door after the first possible seizure. So, and then the ER's kind of worked them up. So, but you still want to know, was it witnessed or not? Did they have a warning sign? And the motor activity, like where did it start in their body? Was it on one side or both? Did they have any associated signs like, did they get blue in their face or around their lips? So did they get cyanotic? Did they lose consciousness? Were they incontinent, which is more worrisome? Were there any precipitating factors? Did something like bring it on, such as an activity? Did they stop taking their anti-seizure meds if they were on them? Were they really stressed out or really fatigued? Did they have a postictal phase? Were they confused, weak, have a headache, any kind of muscle aches? So things like that. When it comes to tremors, I want to know, did it seem to grow worse with them trying to do something, like with intention, like where they're trying to do an activity, and it made their tremor worse? Were they anxious, or did they have it at rest? How are these things affecting their daily life? With weakness, is it generalized or local? Is it hard to open a jar or write or use any kind of implement like a scissors, or walking? Is that an issue? Unfortunately, my husband had a stroke about a little over a year ago, and his only symptom at first, where you would want to take him because he was starting to have the stroke, by the time he got more like classic symptoms, he had already had the stroke. His only symptom was his hand. I believe it was his left hand. He said he couldn't hold anything in it. He was dropping stuff. So, and then with incoordination, they have problems with balance. Are they falling? In which way? Are their legs giving way? Do they have clumsy movement, numbness, tingling, difficulty swallowing, speaking? Any history of any kind of neurological issues like a stroke, spinal cord injury, infections like meningitis or encephalitis, congenital defect, alcoholism? Are they exposed to any environmental or occupational hazards such as insecticides, organic solvents, lead? Are they taking any mind-altering or mood-altering drugs such as marijuana, cocaine, barbiturates, or tranquilizers? It's a lot of information, and it just keeps coming. So with our patients are two different. So those were just our adult patients. So when we're talking about our pediatric population, especially infants, we want to know mom's OB history, which we may or may not know as well. But did she have any infections or illnesses? Did she have PIH, pregnancy-induced hypertension, toxemia? Was she taking any medications, using drugs or alcohol? Is she a diabetic, or did she develop gestational diabetes? Was the patient a preemie or full term, which can be, birth weight, any kind of birth trauma that could contribute to the problem? What were their APGARs, which can be tricky trying to find those. I'm now lucky in that where most of my infants are born, the hospital and I share Epic, so I can see APGARs now. But did the patient have congenital defects, reflexes? Some reflexes we expect, depending on the age of the patient. Some should not be present. Are they persisting? Does the infant either bottle or breast? Is there suck and swallow? Is it coordinated? Is a patient turning their head to touch? So if you touch their cheek, are they going to turn their head? Do they startle to a loud noise? Do they grasp your finger? So basically, are they meeting their developmental milestones? Depending on the age of the patient and stuff. It gets a little tricky depending on when you're wanting to know about balance and are they having issues with, like clumsiness, falling, and unsteady gait, because it depends on how old the patient is. Because if they're only I would say between 10 and 15 months, they're just learning to walk. So they're probably going to be clumsy and fall. So, but if they're an older toddler, say 18 months to 2 years, they should have been walking for a while. So they shouldn't be clumsy or nearly as clumsy. So now, is that getting worse? Are they really falling down? Do they have this unsteady gait? Any kind of muscle weakness? Issues going up and down stairs? Have they been exposed to any kind of environmental hazard like lead? Do they have a past medical history of seizures, febrile seizures? Typically, we see in young children, cerebral palsy, muscular dystrophy. And then when we're talking about our aging patients, they tend to get more dizzy. So is it with standing, sitting, just moving their head, walking? Is it their medication? Men who get up at night to void, are they dizzy while they're standing? Does the dizziness start while they're peeing? Can they drive? We want to assess their memory. Is it a little memory loss, or are they confused? Do they have tremors? Do they have any visual changes? Okay, so the exam. Okay, so this is the information. This is the equipment that you want to gather. So you can use your otoscope or your ophthalmoscope, in lieu of a pen light. I'm thinking though that a pen light would work even better because the light is really bright. So I'm even thinking about starting to use my pen light more. A tongue blade, cotton swab, cotton ball, tuning fork, and a hammer. I have typically used my stethoscope in lieu of a hammer, so you could do that in a pinch. But the next slide is where, and then this is the sequence in which you're going to do your exam. So you want to assess the patient's mental status, their cranial nerves, their motor system, sensory system, and their reflexes. Okay, so the point I was trying to make is when you're watching the video, especially the 4-minute neuro exam, I think the guy does a really nice job. And you can, you don't have to have a lot of fancy stuff. Your tuning fork, your hammer, a Q-tip that you can use, and then you're good to go. And like I said, in a pinch, if you couldn't find your hammer or you didn't have it with you, you could use your stethoscope. And I'll show you how you can do that. So this is a point where you watch the videos. Okay, so the next few slides are going to be talking about abnormalities that you see, and the point I want to make here is that it goes through different muscle tone, muscle movement, things like that. And most of the time, I don't diagnose patients with this. They have it because they have another issue. And I think things that you are going to see that are common, for patients who have cerebral palsy, for instance, they'll have spasticity or plasticity, and I think that's pretty common. Or somebody who has spina bifida, they could be, have the same. They could have paralysis. You could, have a patient who has a seizure disorder. So I typically, in my practice, the things I see that are normal when it comes to neuro is headaches, dizziness. I have patients who have seizure disorders, but they're on medication. And then if I'm worried about a patient having seizures, I will start the workup, and I typically will refer them to the neurologist. So if I had a patient who I was trying to rule out, like Parkinson's, I would probably refer them to. And then patients who have abnormal gaits, typically it's because of the Parkinson's, or it might be because they had a stroke, or they have some other underlying reason why they have cerebellar ataxia. And this is just a symptom of it. And then again, common patterns of motor system dysfunction, which we've discussed: cerebral palsy, muscular dystrophy. They could have had like a they could have hemiparesis because a stroke. They could be a paraplegic because of some kind of trauma. They can have MS, and then it could affect their motor system. And I see a lot of patients that have this kind of stuff, this common pattern of sensory loss, typically because of peripheral neuropathy. Okay.